Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF-Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF-Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF-Derm experience.
A 49-year-old man with end-stage liver disease, acute on chronic renal failure, septic shock, multifocal pneumonia, cerebellar, splenic, and renal infarcts, on the antimicrobials caspofungin, linezolid, azithromycin, and meropenem. So really, really sick. And we get called for these skin lesions. And I have to tell you, I was fooled for a good while and underplayed the significance of these skin lesions. So I want you to see what I didn't see in the beginning, which is you still have that hemorrhagic bulla, and you still have that surrounding retiform purpura, okay? And then you still have that central area of eschar. So you're still in that same differential diagnosis of what's going to kill the patient, angioinvasive infections. And there's the retiform purpura. And cultures here grew mucor, okay? So which brings me then to talk about angioinvasive fungal infections. So there are two main ways to get angioinvasive fungal infections. Primary cutaneous, which means direct inoculation into the skin and then spreading elsewhere, which is actually less common than what we see in the hospital, which is cutaneous secondary infection, which means it's coming from somewhere in the body and then moving to the skin. And the most common places that it comes from are the sinuses or the lungs. So the other way, the one caveat to that is the direct invasion from the orbits, the sinuses, onto the facial structures in rhinocerebral mucor. Okay. And it's important to have a sense of like which organisms do what. So for example, the lungs and sinuses to the skin, mucor likes to do that more than aspergillus does. And if it starts around the nails, a paronychia or onychomycosis, then that's much more likely to be fusarium. So there are some trends to recognize. And so why would I be telling a group of dermatologists and scientists who really don't spend a lot of time in the hospital about this? Why would I spend a lot of time on this? And that's because 3 to 5% of the US population is immunosuppressed. And invasive fungal disease is the leading cause of morbidity and mortality in this population. And we immunosuppress our patients all the time, and we take care of immunosuppressed patients all the time. So it's this information that we should know. So Candida and Aspergillus are the most common organisms. Which one is higher than the other in terms of likelihood really depends on your patient population, but for all things considered, those are your numbers 1 and 2. But there are some interesting trends that are on the horizon that are important to know about. So first, acute respiratory infections increase the risk of invasive fungal infections. So for example, patients who have influenza with pneumonia are much more likely to also have co-infection with Aspergillus. And we knew that was true in the COVID pandemic because we were seeing patients who had secondary infection with mucor in their lungs. So that's an important thing to know. There's a new Candida out there called Candida auris. I have not seen skin infection to it yet, but it is resistant to fluconazole, and 50% of them are resistant to amphotericin. So that's important to know. There are lots of non-Aspergillus fumigatus species that are now arising, and so knowing the organism, knowing the species is going to impact how we treat patients. Mucor is on the rise, fusarium is on the rise, Cedosporium and Lamentaspora are on the rise, and in the last 2 years, I think we've had somewhere between 8 to 10 cases of either Cedosporium apiospermum or Lamentaspora prolificans, and those are really bad infections. Cedosporium apiospermum is sensitive to voriconazole, tends not to be as fulminant. Lamentaspora prolificans is pan-resistant and almost universally fatal. There's a new dimorphic fungus called the emergomyces, not a very creative name. It does give skin lesions. I haven't seen it yet. And there are new species of blasto and histo that are out there, and we used to think about geographic areas really limiting our workup to one or the other. But now we know that there's tons of cross-pollination, and we need to be thinking about all of these everywhere in the U.S. And so what are some clinical pearls that help you when you're looking at a patient at the bedside to think through which fungal infection might be more likely? So first you want to think about the purpuric border, a hemorrhagic bulla, and a purpuric nodule. That all makes you think more likely to be invasive fungal. If you're going from the lungs and sinuses to the skin, it's much more likely to be mucor than aspergillus, even though aspergillus is a more common organism in general. As I mentioned earlier, if it's a paronychia, remember fusarium, 33% of them start as a nail infection, usually on the toe, either as a paronychia or an onychomycosis. If you have few lesions that are large, so few in number, large in size, mucor aspergillus. Scattered small purpuric lesions, maybe with central necrosis or central pustule, more likely to be candida or fusarium. And then start empiric amphotericin if you are clinically suspicious, right? Okay, so Aspergillus fumigatus, this is an example of a hemorrhagic bulla with a purpuric rim. Another example of the necrosis with the purpuric rim at the edge. Okay. And an example of a chest tube insertion with what was a hemorrhagic bulla, and now you're seeing mostly crust and necrosis, but you see that surrounding purpura. A case that I saw when I was a resident with Adam Rubin, who's at Penn now, you can see that there's a purpuric plaque, and you can see where the biopsies were done at the edge. But over time, what has happened is what's called the bullseye infarct of mucor, and you can hopefully appreciate this purpuric rim that I talk about. So this 2 millimeter purpuric rim here is a good sign that you've got an angioinvasive organism. This was a case that I saw when I was my first year as a faculty, and I was at Yale, and I was called to see this toenail that was thought to be onychomycosis. This patient had AML, and without saying too much, this was the physician who was taking care of this patient is married to a very famous dermatologist, and that oncologist didn't want me to touch the nail, so I didn't. But what happened over the 12 days is you can see very much a morphology that was similar to the other areas that I showed you with the central necrosis, and that toenail eventually fell off. This ended up being disseminated fusarium with many small 2 to 3 millimeter, maybe 4 millimeter purpuric papules with central necrosis. This was also an example, and the only one that I can find, of why patients get muscle pain when they get disseminated fusarium or disseminated candida, and that's because they actually have little abscesses going straight to their muscles. A recent example from our service at UCSF, again, disseminated fusarium starting in the toe, very similar morphologies, smaller lesions, central necrosis. Disseminated candida in a patient with AML, and this is why I teach that acne isn't acne in the hospital, right? Okay. And so let's just think about some diagnostic considerations when you're thinking about invasive fungal infections. The first is that you cannot reliably differentiate organisms on H&E. So whenever you're doing a biopsy for H&E, you have to send one for culture as well. And tissue invasion is important to demonstrate. So let's say that you get a scope of the sinuses and Aspergillus grows. Aspergillus lives in all of our mucosa. A lot of other, fungal organisms do as well. So if it's just sitting there and it's culture positive, doesn't actually mean that that's causing disease. So you really want to demonstrate that there's invasion of that organism into the tissue that you're evaluating. Galactomannan as a marker of infection is really only picking up Aspergillus. Compare that to beta-D-glucan, which is a component of various cell wall fungi, and so it is able to pick up a lot of organisms, but there are loopholes. It does not pick up crypto or mucor. And there's cross-reactions between antigens, histo and blasto, cocci and paracocci, so you're not always going to get the perfect answer. There's a lot of reason for cryptococcus testing that can be false positive in disseminated trichosporinosis, which I have seen, capnocytophagia, and in the setting of a positive rheumatoid factor. And false positive and negatives with any kind of either culture or serologic marker is possible. And because it depends a lot on the degree of invasion and how much organism you have to make sure that it can actually be picked up by the test you're using. So there is room for false positive and negatives in your testing. There are also some therapeutic considerations. There's a lot of increasing antifungal resistance. Aspergillus fumigatus has increased resistance now to azoles. Candida glabrata is 10% azole resistant, 4% echinocandin resistant. And it's thought to be driven by climate change, agricultural practices, and globalization. So this is where climate change actually is impacting what we're seeing in clinical practice. Treatment considerations. Voriconazole doesn't treat mucor. This actually means that if a patient is prophylaxed after a transplant with voriconazole, which is being used less now for this reason and many others, you actually may get a breakthrough infection with mucor because you're not protected against it. Echinocandins is first-line therapy. It's great for Candida and Aspergillus and some dimorphic fungi, but there are a whole host of organisms it doesn't treat. And as I said before, L. prolificans is pan-resistant. It's almost always universally fatal. Okay, so my summary points: angioinvasive infections, think about gram-positive, gram-negatives, and fungal, broad workup, broad coverage. Invasive fungal infections, morphology guides your differential diagnosis, and emergent organisms and resistant patterns are important to recognize. When it comes to Cryptococcus, cellulitis is the most common presentation in organ transplant recipients. Inoculation disease is a diagnosis of exclusion, and Sweet syndrome is a mimicker, histologically. And hyperinfection strongyloidiasis, remember periumbilical purpura, and you do not have any eosinophilia. I always thank the Derm Foundation, the MedDerm Society, and my baby, the Society of Dermatology Hospitalists, for support, and thank you very much.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.